So conventionally, for MSKs, we go for agents, side effects. They try to aim to decrease the pain rather than targeting the underlying pathophysiology. To overcome these, the field of regenerative medicine has come out. We all know it's a process of creating living functional tissues to repair or replace tissue which is lost to age, disease, damage, or any congenital defects. This cartoon just shows it in from the field of tissue engineering, biomaterials, and stem cell therapy. So what are regenerative medicine treatment options? Could be both autologous, as we talked about, things derived from peripheral blood, or sources derived from the umbilical cord. I'll focus more on the peripheral blood, and this does not include BMAC or the adipose tissue. So when we talk about PRP, we see like various takes, various ways to literature, and what we hear from all our colleagues. Sometimes we say, hey, PRP works. Sometimes we say PRP does not work. Why so? Lack of standardization. What they suggested, whenever you do PRP, what is a must is you have to classify the platelet counts. So we know the platelet count normally in a patient is 150 to 350 K. Again, we hear that, hey, we have to hit those 5 to 7 times the PRP, the platelet count. Should translate to about 1.5 million platelets per micron times the concentration. So there are like different types of cells that we use. They're actually good. The platelet count goes up, comes down, goes down. So it's directly proportional. So when people try to say, hey, I'm going to go leukocyte poor, it's fine, but always watch for your platelet count. RBCs, another plate touched on. So we published an editorial on it. It's bad. If you end up lysing it, it releases free hemoglobin, iron, and heme. It leads to activation of inflammatory pathways, which is bad. Also acts via eryptosis, leads to secretion of this MMIF, which yields inflammatory signals, and it can also hinder proliferation of fibroblasts and migration of stem cells. Another study I came across, it's a preclinical study, which shows even in BMAC, RBC depleted BMAC leads to secretion of more anti-inflammatory cytokines compared to the regular BMAC, and it gave better outcomes as well. Another topic I wanted to touch on is the effect of common medications on platelet count. In certain presentations, we just saw, hey, we need to stop these medications. But why are we doing so? So we know that too low or too high platelet count can hinder PRP efficacy. There are two factors which are indicated to affect the efficacy of PRP. The platelet count, it's correlated with concentration of growth factors, and aggregation because it's essential for platelets to secrete those growth factors. So there are, again, certain patient variables which we have to count for when we talk about PRP. The medications, smoking status, alcohol consumption, all of these. Here we're going to focus on the medications. Why we are focusing on medications? There are very limited studies on common medications consumed by patients and their effect on the PRP, and there are lack of detailed guidelines pertaining to which medications should be brought prior to the PRP injection. So we summarized this table where we found that common meds like aspirin, acetaminophen, non-selective NSAIDs, you should suspend them before a PRP because they interfere with the platelet aggregation. However, COX-2 selective NSAIDs like etoricoxib, they are okay. We summarized all of these in another editorial where we discussed all these medications in detail. So certain questions we always encounter is how to test for platelet and leukocyte count in a clinical setup. Answer is very simple. Run a CBC, a lot of you do it on the whole blood. When you prepare a PRP, you can always sum of it, again run a CBC on it. And we did that, even on the platelet poor plasma, the one we should be discarding. As you can see, there is nothing left in it if done correctly. So what it gives, what we talked about, the platelet count goes up to 5 to 7 times. Neutrophils, the bad ones goes down, good lymphocytes goes up, and RBCs are depleted. Yes, can't get rid of 100% of those, but there are still some left. Example, for precursor PRP, they were nice enough to share their data with me, and we can see RBC was depleted, platelet count goes up, lymphocyte goes up, neutrophil goes down. Similar results with their like smaller tables. Question is, does PRP work? So based on the most recent level 1 evidence, this study consists of 24 RCTs, showed most of the patient-reported outcome measures went up in PRP group compared to saline and HA. Again, saline and HA are not the best comparators to compare anything to. What is better, leukocyte-rich or leukocyte-poor PRP? So came across this study in AJSM showed all proms went up in both the groups, no differences between the groups. Another study showed the same outcomes. We summarize these in another editorial. What about indications other than knee OA? So came across these studies which talked about that PRP in lateral epicondylitis, both works whether you go for leukocyte-rich or leukocyte-poor, however, no differences between the two formulations. Same thing, we came across a recent systematic review, both work, but no differences whether you go for leukocyte-rich or leukocyte-poor. So it's people's own preference that, hey, I prefer leukocyte-rich or leukocyte-poor, but clinically there are no differences. Another thing we have been encountering lately is does combining PRP with HA work? So came across this study with 60 patients, did 3 groups, PRP alone, HA alone, and combination, and they found significant improvement in the VAS score compared to both PRP or HA alone. Similar outcomes were reported by this recently published systematic review and meta-analysis. We did an editorial summarizing these as well. Recently, I came across another group in France. Their theory is they should be done a week apart, and they also got good outcomes by putting PRP and hyaluronic acid a week apart. So the take home is when administering PRP as a therapeutic agent for any MSK, the doctor must be aware of the quality of PRP being delivered at the target site, the factors responsible, and the medications interfering with the homeostasis of the PRP. What are the limitations? With PRP, we know there are variability in formulation protocols. Most of the studies done have a small cohort size. They have short to mid-term follow-ups. And the most important, we've been talking about so many of these like biologics, but there is no literature out which compares one orthobiologic to other. We have so many options just within the peripheral blood. How about comparing it to BMAC or SVF? Even when we talk adipose, we are like, hey, how about microfat, nanofat versus SVF, and then we jump into the other field of the allogenic sources, umbilical cord, amniotic-based, exosomes. So it always leaves an open question for all the physicians, which one should you be using for what? So I think more studies are needed which compares these orthobiologics so we can decide what to use. With that, yes, I have recent reviews which we summarized the use of autologous conditioned plasma in NEOA, just wrapping up. And also on hyperacute serum, unfortunately, there is one study on that. So one point I definitely want to highlight on the ACP was, so we always consider randomized controlled trials as the gold standard. So what I found interesting while doing this review article is,